Hello everyone, welcome to the next module of history taking. In this, I'll be discussing with you how do you take the personal history as well as the menstrual as well as the obstetric history of the patient. So in personal history, very essential to know three things. First of all, smoking, tobacco as well as alcohol. These are the addictions which we are talking about. Apart from that, what is their sleep, what is their dietary habit, and what is essentially if they are having any problem with respect to bowel or bladder. So these are the few things that we elicit with respect to the personal history of the patient. Now, apart from all of this, there are a few other points which are written in some books which include the marital history as well as the occupation history of the patient. Let's talk about smoking first and then we'll talk about all the other things, because smoking is a very common thing that all the Indian patients that do. If you are in a ward, you will always see people sneaking out of the ward for smoking and coming back after taking a cigarette or two. So please make sure that you always ask the patient, male ho ya female ho, you ask them about their smoking habits. What kind of cigarettes are they smoking? If they are smoking some BDs, what are the different kinds of things they are taking on a day-to-day basis? Nowadays, we are seeing that teenagers as well as young adults are going into vaping. So if you can also elicit the history of vaping in a person with pneumonia or something else, it would be really good, and it would add a charm to your presentation of the case. For calculation, we use index called as pack years with respect to smoking. So as the name suggests, pack years is exactly how we calculate it. Number of packs consumed per day times the number of years that the patient has consumed. So let's say that the person consumes one pack of cigarettes in a day and the person continues to do that for 20 years. That will be 1 into 20, that is 20 pack years. And this pack years is a very good indicator of whether or not the patient will develop some smoking related complications in the future. So it is always said that a pack year of more than 20 is very dangerous, and if it goes beyond 40, a patient has a very high risk of developing lung cancer, which is common with smoking. Apart from that, smoking predisposes you to all sorts of different things like atherosclerosis, like esophageal cancer, gastric cancer, urinary bladder cancer, impotence, as well as atherosclerosis in your cerebral vessels that might be detrimental. So these are the few bad effects of smoking that the examiner might ask you. Smoking also has a few protective effects, but those are better left unturned. Never smoke because it has got some protective effect. Just to name a few, it is protective against ulcerative colitis. Smoking is protective against fibroids and also preeclampsia. Smoking is protective in all three of this. Somehow the mechanism is unknown, but that is no justification to anybody smoking a cigarette. So this is with respect to smoking. You have to remember to mention the pack year. That will give you a good advantage over your other students who might not mention it. Next thing, let's go over to alcohol. So alcohol there are variety of alcohol available in the market. So we've got desi daru, non-desi daru, we've got whiskey, vodka, wine, all of these things. Now all of these alcohols we differentiated by the amount of actual absolute alcohol they have in them. So beer is very low, like 2 to 3%. It can go as high as 5 to 10%. Then we have got a bit more higher ones, wines and all. And vodka we have like very high concentration, 80 to 90% of alcohol. So how do we calculate how much alcohol a person is taking and whether the person lies in the safe category or the unsafe category? So we use this term called as alcohol unit, and 1 unit of alcohol is 10 ml of absolute alcohol. That means 100% alcohol. So you calculate how much units of alcohol a person is consuming, and if it is more than 21 for males per week, then it's very dangerous. And if it's more than just 14 for females, it's very dangerous. One thing that they can ask you is that who is more prone to development of cirrhosis, whether it's a male or a female. Females are much more prone to developing liver cirrhosis when they are consuming alcohol than males. Males have a higher tolerance. I don't know why, but it's just the case. So alcohol is very essential, and you can definitely mention how many units of alcohol is the person taking. This is a sensitive history, so if you're in a private practice, make sure that you elicit it properly with respect to the patient. Don't make them feel bad about their addictions because they might be struggling themselves. So this is very essential that you as a doctor always treat your patients with respect. Does not matter what the patient is hailing from, what is the differentials of the patient. Lastly, we've also got tobacco smoking, which is present in India. So tobacco will lead to a lot of different oral cancers, and whenever you are taking the history of some oral swelling or some cancer like CA buccal mucosa, CA tongue, in that case you will have to elicit the history of tobacco use. Apart from that, substance use is also present. So if you can get what kind of substance abuse is the patient doing, heroin, cocaine, methamphetamine, it might be marijuana, it could be cannabis, it could be anything. So if you can write that, that is well and good. The other things with respect to the personal history are the sleep. So how many hours is the sleep happening? Is the sleep disturbed? So in the case of hepatic encephalopathy, one of the first things the patient experiences is they cannot sleep in the night, and in the day they are very sleepy. So that is one thing. Bowel and bladder habits, are they regular? Are they having any issues? In the bladder, particularly in the older age group, patients may complain of hesitancy, frequency, nocturia, urge incontinence. All of this are signs of prostate, enlarged prostate. It could be benign prostatic hyperplasia or it could be CA prostate. So you have to keep in mind all of these things with respect to the bowel and bladder habit. So that was all that you needed to do in your personal history of the patient. Remember, tobacco, smoking, alcohol, you must never miss. This will give you an additional point to get your diagnosis in front of the examiner. Next, in the personal history, we also talk about the marital status. How long has the patient been married? Do they have any children? And that gives us the idea about the infertility or all if the patient is suffering from something. Next, we move on to the other type of history that is specifically we have to take only in the females, that is the menstrual history, the obstetric history, and the gynecological history. Let's talk about the menstrual history for a second. Menstrual history, we have to take 4 or 5 different things. First is the age of menarche. That means when did the person get the first menses? What is the age of the person? Most of the times, if you're in medicine ward, you might get a very old lady, like 65 years of age. She might not remember a menarche, so you can write an approximate age of 14 or 15. Next, we have to write how much is the duration of the cycle. So it is a 28-day cycle, it's a 30-day cycle, 35-day cycle. Next, the quantity of blood that is lost during each menses, so that you can assess by the number of pads that a female is using. Next, we go over to a menopause state. So if it's an elderly female, they might already be in the menopausal age group. 46, 47 is the mean age group of menopause in India. In other countries, it is a bit less. So menopause is something which you have to also ask for. If it's a very old lady, don't be like that person. If it's a 65-year-old female, you are asking them, when does your period come and all, they will probably slap you because they are a very old person and you must not ask that. You must ask directly, what is the menopausal history? Why is this important, my friends? Especially in OBGYN, it's important. In older age group females, it's important because after menopause, if you're having some bleeding, that's called as the post-menopausal bleeding. And it's a very, very serious condition to have. Most of the times, it is not anything. It may be senile vaginitis or some cervical issue, but it can be a sign of endometrial cancer. It might be a sign of cancer cervix. It might be a sign of some vaginal cancer or the vulval cancer. So postmenopausal bleeding is a very big thing that you always have to keep in mind. Next, whenever a reproductive age group female comes to you, always remember that you have to do a UPT if possible to rule out pregnancy, especially if you are sitting in an OBGYN setting. In a medicine setting, if you don't do an UPT, that's okay. But if you're sending the patient for some sort of an X-ray or a CT scan, UPT is must because the fetus should not get exposed to any sort of radiation. While asking about the periods about a female, you have to also ask about the LMP, that is the last menstrual period. What was the last date she was bleeding? And that date should be the first date of her period. So let's say that her period started from the 1st of this month and she bled till 5th, the LMP will be 1st. So it will be 1st. So that is the first day of your last menstrual period. You also, if the patient is pregnant, you have to ask about the expected date of delivery, that is the EDD. How do you calculate it? From the LMP, you add 9 months plus 7 days. That's called the Neglis formula. So 9 months plus 7 days. So let's say if it is 14th of February, at 9 months, it will be 14th of November plus 7 days. That is, will be giving you 21st of November. So that is exactly how do you calculate the EDD from Neglis formula. These are the few things that you must include. Of course, in the obstetric history, you might include the GP formula. So gravida, parity, alive children, and the abortions. So all of these can be included as well. So that we'll take in detail when I'm teaching you the obstetric history, but these were a few points that you have to remember. Lastly, there is the socio-economic history that is only going to be taking in PSM. So that you have to include what kind of house they are living in. Kacha makan hai, pakka makan hai. Do they have a sanitary well nearby? Are there mosquitoes nearby? Is their house well ventilated? How many windows are there? How many doors are there? That is specifically with respect to PSM. In medicine, we don't do all of that. So that was basically all about how you take a history. Like I said, last time I summarized with you everything. This time, let's summarize it once again so that it all goes permanently inside your head. First of all, when the patient approaches to you, you will always be respectful to the patient and you will treat them with utmost privacy if that's the concern. Next, what you will do the demographic data of the patient, the chief complaints, the history of presenting illness. Then you will take the negative history of the patient and then you will go over to the treatment history. After treatment history is done, you will take the past history of the patient. Then you will do the family history of the patient. Next, you will go over to the personal history, menstrual and obstetric history with a female. And lastly, 10th point is the socio-economic history of the patient. These are the 10 points of history taking. And if you present your history in this way, you will be able to narrow it down to anatomy, etiology, pathology, the 3 things like I told you to narrow it down to. By the end of the history, you should have a good idea about what the provisional diagnosis of the patient is. Let's say that the patient is a hypertensive male in his 60s. He is also having some sort of headache. He is also having some sort of chest pain and he is having basically breathlessness. You might be thinking in terms of maybe something like a MI or maybe something like an angina that is happening. If the person complains of weakness, you might be thinking of a CNS disorder. If a patient is complaining of abdominal pain, you will be thinking in terms of GIT. Agar khasi hai, so you will be thinking in terms of RS. So these are the few things by the end of your history you should be able to narrow it down to. And please make sure that the history you're telling in your patient's language, you don't have to use complicated medical terms, especially during chief complaints and HOPI. Do not use the complicated medical terms, right? You have to use the patient's language and how they have told you. That is the way that you present your history. After After this particular 10-point history is done, the examiner might tell you to summarize this. So this is how you exactly summarize your history. You can see there are 2 paragraphs on the screen. The first paragraph includes your basic positive findings of chief complaint and a few bits of HOPI, and lastly a few of the essential negative findings and a few relevant positive findings from all the other histories that you have taken, and that's how you summarize it. I've got a link in the description which you can access, and you can see the few cases which you have written, and from that cases you can get a good idea of how to write a beautiful history. I hope that this masterclass on history taking has really helped you out, and of course if you need any help you can email on this particular email address and our team will help you out definitely. Moving on, I'll be talking to you more about the general examination, the systemic examination of the patient, which is very amazing, and I'm very excited to show you all of that. So are you ready? Let's go, my friends.